So by now we have seen how the drug is absorbed. That means how the drug reaches from the site of administration to the blood. Now today we are going to see the another component of pharmacokinetic, that is drug distribution. Drug distribution, that is the delivery of the drug to tissues. We know that it is not uniform. Why? Because it depends on the rate of tissue blood flow, that is the perfusion of the blood. Organs which are having greater perfusion, for example, heart, brain, liver, kidney, lungs, they receive most of the drugs within few minutes. Therefore, these vital organs are more susceptible for drug toxicities. Organs with poor perfusion like muscles, other viscera, skin and fat, they receive drugs slowly. Tissue mass is also not deciding factor. Small tissues, if highly perfused, receive a major amount of drugs. So organs with greater perfusion, they receive major amount of the drug, and this is the reason why the vital organs like brain, heart, liver, kidney, lungs, they are more exposed to the toxicity of the drugs. Another factor that contributes to the distribution is the extent of plasma protein binding. A drug can bind with plasma proteins. This binding is by weak bonds, so it is reversible. Drugs differ in their degree of plasma protein binding. Extensive plasma protein binding reduces the distribution since the drug is now held in the plasma. It is the unbound drug that is active and can produce response. Drugs bind mainly with albumin, that is acidic drugs. So acidic drugs bind with albumin. Basic drugs bind with alpha-1 acid glycoprotein. Drugs can also bind with transferrin, celluloplasmin, etc. Few drugs, for example, sex hormones, they bind to the specific hormone carrier proteins, sex hormones binding globulin, etc. Now let us think that what is the clinical significance of this plasma protein binding. We know that it is a free drug which is active, which is diffused through the capillary wall, which is metabolized and eliminated. That means the bound form is inactive. It is just acting as a circulating reservoir. So the bound form is neither metabolized nor eliminated. It remains as a reservoir. Extensive plasma protein binding reduces distribution, so delays the response and prolongs the duration of action. Plasma protein binding helps in the lipid soluble, helps the lipid soluble drug to carry in the plasma. Protein binding of an acidic drug reduces in hypoalbuminemia and nephritic syndrome because there is reduced albumin level. The binding of a basic drug increases in acute phase reactions since there is increase in the alpha-1 acid glycoprotein. So in conditions like myocardial infarction, surgery, neoplastic disease, rheumatoid arthritis, and burns, the free fraction may get reduced because the protein responsible for binding, that is increased. This plasma protein binding is non-specific in nature. Many drugs bind at same binding site, so they compete for plasma protein binding. A drug with higher affinity displaces the other. Therefore, the free concentration of displaced drug increases that can enhance the pharmacological effects. It may enhance the toxicity of that drug. So we know that warfarin, that is an oral anticoagulant, that is displaced by salicylate. So more free concentration of warfarin, that means there is more risk of bleeding. Similarly, tolbutamide, that is a hypoglycemic agent displaced by salicylate. Therefore, there could be hypoglycemia, excessive reduction in the blood sugar level. Sulfonamide displaces bilirubin, which in infants cross blood-brain barrier and get deposited in basal ganglia, and that is the reason for kernicterus. In most of the cases, this displacement leads to a transient rise in the concentration. Since more is the free drug, more is the metabolism and elimination, hence a new steady state is achieved. But this transient rise in free concentration that can produce toxicity if drug has a narrow safety margin. The safety margin with the drug is narrow. If the displacing drug also reduces the elimination and metabolism of display drug, for example, phenylbutazone, that displaces as well as reduces metabolism of warfarin. Salicylates also inhibit tubular secretion of methotrexate. So in that case, the drug can create the clinical problem of the toxicity. Then extent of tissue binding, that is the preferential accumulation of the drugs. Some drugs, for example, alcohol distributes throughout the body, but other drugs are not uniformly distributed in our body. Some tissues are having special affinity for particular drugs. For example, kidney, heavy metals like cadmium, lead, and mercury get deposited in the renal tissue. Eyes, chlorpromazine, that is an antipsychotic drug that can produce retinal pigment retinopathy. In bones, there is excessive deposition of tetracycline, lead, radium. Liver, chloroquine deposited in the liver cells. In the fat cells, thiopental, and in GIT, weak bases like morphine that is accumulated in the stomach. And this is the reason that gastric lavage is useful even if poisoning with the morphine is by parental route, because it comes secreted in the stomach where the pH is acidic, morphine is basic drug, so it gets ionized and gets trapped there. Therefore, gastric lavage will help in the removal of this drug. Then the next factor is the physiological barrier, that is the permeability characteristics of specific tissue membranes. These barriers protect the particular organ from toxic effect of drugs. It could be blood-brain barrier, where there is absence of intracellular pores and pinocytic vesicles. Tight junctions, they are predominating, and so drugs may pass through cells only, that is through diffusion. Hence, only lipid-soluble drugs can cross the membrane. Ionized, water-soluble drugs do not cross. Glial cells, which also contribute to slow diffusion, envelop the capillaries of CNS. P-glycoprotein in the brain capillary cells also efflux the drug out if it gets the entry. But remember the fact that this barrier, blood-brain barrier, it is not a perfect barrier. Inflammation may disrupt the integrity of the barrier, so drugs can cross during inflammation of meninges or encephalitis. Some parts of CNS are behind the limit of blood-brain barrier, for example, area posterior and pituitary glands. Another one is the placental barrier, where the drugs can cross the placenta by simple diffusion. Lipid-soluble drugs easily enter the fetal blood flow from maternal circulation. Fetal liver is immature, placenta is capable of metabolizing, but with limited capacity, so drug remains unmetabolized, may manifest toxic effect. Therefore, the drugs can cause congenital anomalies or adverse influence on the baby if administered during pregnancy. If taken during pregnancy by mother, it can lead to the problem to the baby. This is teratogenesis. Examples are phocomelia by thalidomide, bony abnormalities by oral anticoagulant, cleft palate by methotrexate, spina bifida, deep discoloration by tetracycline. So we will cover this topic in further details with some other the drugs affecting the maternal function. Then we will see maternal pharmacology and that. But till that, here is the diagram showing some of the teratogenic influence of the drugs. So you try to identify this. We'll discuss them in details. Here we have seen distribution, that means the delivery of the drug from blood to tissues. Delivery of drug from one tissue to another one, that is known as redistribution. So drug effect usually terminated by metabolism and excretion, but sometimes it is terminated by redistribution from its site of action to other tissues. For example, thiopental that is redistributed from brain to fats, so onset of anesthesia is rapid and so also is its termination. Fat acts as reservoir. When these sites get saturated, the termination of effect depends on metabolism and excretion, and thus a short-acting drug can show effect for a long period if it is used frequently or in higher doses. That's why thiopentasodium is not used by intravenous infusion. It is used only for induction of penicillin, not for maintenance. Now another one is the volume of distribution. Volume of distribution is the imaginary volume that relates the amount of drug in body to concentration in the blood. Suppose our body has a single compartment like a drum containing 5 liters of blood and drug is equally distributed in this. So if we administer 100 milligram of drug, the concentration will be 100 divided by 5, that is 20 milligram per liter. So concentration in blood is equal to drug in body divided by volume of distribution, total volume where it is to be distributed. Therefore, VD, volume of distribution, is equal to drug in body divided by concentration in blood. So that is just we have rearranged the formula. So volume of distribution is equal to dose divided by concentration, or dose is equal to volume of distribution multiplied by concentration. This one is the initial or loading dose. Therefore, we can rewrite this formula as loading dose is equal to volume of distribution into target concentration. For oral dose, we need to consider the bioavailability fraction, and then LD become volume of distribution multiplied by target concentration divided by F oral. That is the oral bioavailability fraction. Now this volume of distribution, that is the imaginary volume apparent. Because our body is not a simple single compartment. It is having multiple compartments with different types of fluid. So this volume of distribution become imaginary volume. Sometimes we will see that it is more than the total body weight. So that is the imaginary volume that relates the amount of drug in the body to the concentration in blood. Volume of distribution depends on the molecular size and solubility of the drug. Large molecular size extensively bound to plasma protein, they remains in the plasma compartment, so volume of distribution is low. For example, heparin, insulin. A small molecular size but hydrophilic, so gas filter to interstitial fluid, volume of distribution is relatively large. Low molecular size and hydrophobic, it distributes into total body water, for example, ethanol. So volume of distribution in a person of 70 kilogram will be 70 multiplied by 60, that is 42 liter. 60% is the total body water, so that, and highly lipid soluble are the drug if gets sequestered at some specific site. Volume of distribution more than total body water. For example, chloroquine, that is having the highest volume of distribution, that is 13,000 liter in a 70 kilogram patient. Other drugs with high volume of distribution are morphine, digoxin, tricyclic antidepressants, and propranolol. Now let us see what is the clinical significance of this volume of distribution. High volume of distribution. If a drug is having high volume of distribution, for example, tricyclic antidepressant, calcium channel blockers, beta blockers, opiates, fluoxetine, digoxin, chloroquine. So high volume of distribution indicates that there is higher concentration in the tissues and lower concentration in plasma. There is higher lipid solubility or drug got sequestered at some specific site. There is poor binding with plasma proteins. It is difficult to remove this drug by dialysis because less amount is in the blood, more in the tissues. There is requirement of a higher amount, that is loading dose, to get a desired concentration, and there is increased half-life and prolongation of time to achieve steady state concentration. Let us see what is this steady state concentration. For a desired effect, a drug should remain in the blood for a sufficient duration. The dose and frequency of admission are adjusted so that a steady concentration is maintained within permissible limit of maximum and minimum. This is known as target concentration or steady state concentration. If we take the example of theophylline, that is an anti-asthmatic drug. The bronchodilation occurs in concentration of 8 to 10 milligram per liter, while arrhythmia occurs in 20 milligram per liter. So the therapeutic range accepted for a safe and effective use is 10 to 20 milligram per liter. So that is the concentration maximum and minimum that we could achieve. Now also have an idea regarding half-life. The plasma half-life, also known as biological half-life, it is the time required for half reduction of the concentration of the drug in plasma. Half-life of a drug with first-order kinetics usually remains constant. There can be two types of kinetics. First-order kinetic, where a constant fraction of a drug is eliminated per unit of time. Zero-order kinetic, where that is a dose-dependent. Constant amount is eliminated per unit of time. Alcohol, tolbutamide, theophylline, warfarin, aspirin, phenytoin, they are the examples which follow zero-order kinetics usually in higher doses. So half-life and steady state concentration. Steady state concentration is achieved when the rate of admission becomes almost equal to the rate of elimination. This occurs within 4 to 5 half-lives. For example, a drug with half-life 6 hours is given intravenously in dose of 100 milligram. Same dose is repeated every 6 hours. The concentration of the drug in blood will be, after one half-life, 50 plus 100, 150. Two half-life, half of 150 is 75 plus 100, 175. After three half-life, half of 175, that is 87.5 plus 100. After 4 half-life, half of 187.5, that is 93.75 plus 100. And after 5, it will be 96.88 plus 100. So 94 to 97 that we achieve in the 4 to 5 half-lives. Now, what is the significance of half-life? Half-life helps us to assess the time required to achieve target concentration. We have seen just now 4 to 5 half-life. It gives the idea regarding time required for the removal of a drug from the body. It helps in the estimation of approximate dosing interval. It helps in deciding loading and maintenance dose. We have seen that loading dose, that is the initial higher amount of a drug that is used to achieve a rapid effect. Maintenance dose is the amount required to obtain and to maintain a target concentration. So thanks. Enjoy the distribution of the concepts from complicated books to fertile brain. Avoid its reduction and maintain lifelong retention of the concept.